right, well, I've done this right, I hope. It's funny, when we all moved to virtual at the University of Washington on March 6th, people were like, wow, Zoom, it's so innovative. And then, of course, people started talking about, in quotes, Zoom fatigue, but truly it's more the virtual fatigue. I miss people, I miss presenting to people in person. And to add to my anxiety, hooray, a new platform. So I should stop for a second to verify that you do in fact see my screen and that you can in fact hear me. Anybody out there? I got nothing. This is brutal. Awesome. Thanks for the, I did get a comment that someone can see and hear this. So thank you for verifying that. Off to a good anxiety-provoking start. So with that, I'm just going to go ahead and get started. I want to thank Sandy, who's been our contract manager of this project and has been a complete joy to work with, as well as Sarah Mariani, who has been the longest reigning member of Healthcare Authority and Division of Behavioral Health and Recovery to work with our team on this project. This started at a meeting at DBHR that Linda Becker was the chairperson of, and really was this realization that we had the Healthy Youth Survey to collect data on 6th graders, 8th graders, 10th graders, and 12th graders in Washington. We had data on older adults, but there was this very high-risk group of 18 to 25-year-olds where we did not have data. And I'll be talking a bit about this relationship we've had. I also just want to say, at this point, honestly, don't know how many people are on the call because I don't know where to see that with my panel hidden, but I know that so many of the work of you that do this very important work around health promotion and prevention. I hope you know that not only does this matter in a big, big way, it continues to matter. I worry as we get such mixed messages about norms, the impact that that might have. And you're going to be hearing from Mike Graham-Squire about the work that they've done with Most Steer Clear, using King County specific data from the Young Adult Health Survey. But being mindful of things that are influencing norms is really, really important. If you look even just over the past 5 months, in March, stories about no crime to drink wine by yourself. Booze sales are booming as people stockpile alcohol, but it may not last. Today's National Beer Day. Heck, it's National Beer Day every day now. And on the one hand, these were in that first month of the stay-at-home order, but as recently as 12 days ago, the Seattle Times said, everyone's drinking more during the pandemic. I mean, first, that's 1,000,000% not true. And second, pinned human interest stories to the front page of the local paper have a really big impact on norm perceptions and what that means for people. Cannabis was quarantine made for cannabis, and people talking about how cannabis was coming up during this time. And I think that while we look at those types of normative messages, I would just like to, in the spirit of balancing hope and concern, as Jeff Linkenbach would say, look at the fact that there's been big changes in the United Kingdom. Our colleagues at the Department of Health have done a great job of getting information out that explains the risks associated with vaping and smoking. And their infographic has a statement about giving your lungs a fighting chance. I think it's important to shed light on stories like this. 1 million people in the United Kingdom have quit smoking, and this extends to electronic use as well. So for those of you that do this important work around prevention, I just hope you know that it continues to matter, and if in some ways is as important, if not more important, than ever before. Why 18 to 25-year-olds? This is data from SAMHSA, the Substance Abuse and Mental Health Services Administration's National Survey of Drug Use and Health. And it looks at past month cannabis prevalence as a function of 12 to 17-year-olds, 18 to 25-year-olds, and 26 or older. And you can see that this really is the age group that we tend to see the most frequent use as well as the greatest prevalence of use. I work on a college campus. I say that, I feel like I'm lying because I work in my dining room, but I work on a college campus, and certainly we try and be mindful of college versus non-college rates and distinctions, but this is something we, being mindful of the risks in this age group is very, very important. I work in the Center for the Study of health and risk behaviors. Mary Larimer is the director of that lab and is a co-investigator on this. And we partnered with the Division of Behavioral Health and Recovery to conduct the Young Adult Health Survey as a web-based internet survey starting in 2014. And the goal was, let's collect as much data as we can before the first store opened in July of 2014. And as you'll be seeing, the good news is that for the most part, mission accomplished. We made very, very clear from the start, we wanted to use multiple methods for data collection. We get information from the Department of Licensing, for example, and we're able to send a random sample of people with the Department of Licensing address information, an invitation to participate. Depending on the year, we have as much as a quarter of the mail returned, which first of all means that some of people's address information may not be as up to date as we would hope. But even if it were up to date, it only captures people with stable housing. It only captures people with driver's licenses, right? So we wanted to make sure that we also looked at online advertising through other domains as well. What the online advertising brought us was the ability to assess demographics on an ongoing basis. So for example, if response rates in Eastern Washington were lower, we could, in quotes, turn up the dial on advertising in Eastern Washington to modify strategies to recruit any underrepresented groups. We were able to do that as a function of gender identity. We were able to do that as a function of race ethnicity, as well as a function of geographic region. So it is a convenient sample, not a random sample. And as you'll see, in many ways, I think that does represent a strength with this group. To improve generalizability in feedback that we got with our partners at the state, we used post-stratification weights to make the demographic composition of the sample as similar as possible to state census data. So we could analyze the data in more than one way. We could look at the data as they were collected, then we could weight the data to make sure that the demographics of our sample were as comparable to census data as we could. And the weights were based on gender identity, race, and geographic region. What's the good news? The weighted results were very similar to non-weighted. So in the spirit of being as generalizable as possible, and in some ways as conservative as possible with our interpretations, today I'll be presenting the weighted data to you. And we looked at the analyses in a couple of ways. Keep in mind that when we did the survey in 2014, we collected data from a group of 18 to 25-year-olds, and we were able to look at this snapshot in time. By 2015, we followed up with that cohort and collected a new cohort. By 2016, we followed up with the two existing and collected a new, and so on and so on. So we're at the point now where we have 6 different cohorts, and today I'll be presenting a comparison of the different cohorts to each other. And I'll also be sharing with you just from one of the cohorts the longitudinal analyses. So we do regression models where we can compare cohort 1 to cohorts 2, 3, 4, 5, and 6, linear trends from cohort 1 to cohort 6, and even an age by cohort interaction to find out are some of the findings more unique to 18, 19, 20-year-olds or the 21 to 25-year-olds. And then we're able to conduct a model split by over and under 21 to see if the trends differed by age group. So before I start sharing the repeated cross-sectional analyses, let me pause for a moment. I'm going to open the go-to window and see what questions there may be so far, and I can clarify, as well as if there's any audio or visual issues in terms of me sharing and presenting through this platform. So I will pause for a sec. Looks like there are none. If that changes, certainly let me know. Sandy, as the moderator, you can certainly interrupt me if a question has come in for clarification, and I'll just go from there. So in looking at the repeated cross-sectional analyses, sample size over time, every project I'm a part of, I always feel like I'm plus or minus 50 people away from an awesome number, right? We have 12,965 people. For some reason, 13,000 sounds so much cooler, but we'll take it. We've gotten really nice representative samples over time. Again, today I'm going to be presenting to you a comparison across these 6 cohorts, as well as the data from the cohort 1 folks followed up over 6 years. Any past year medical use, we make a distinction in our survey from medical cannabis use and, in quotes, recreational or non-medical or personal cannabis use. There's been a significant increasing trend for 21 to 25-year-olds reporting that they are using for medical reasons. You can see that the regression models were all non-significant. The model split by over under 21. There was a significant trend over time, such that as you looked at new snapshots of people, this is not the same group getting older, that more people in the 21 to 25-year-old group were reporting that they were getting cannabis for medical purposes. When we look at norms, those are going up over time. And keep in mind that why norms matter is we have decades of research that show that when people perceive, in quotes, that everyone uses, for example, they're more likely to initiate use themselves or have their own use persist. There's research that also shows that the more pronounced a misperceived norm, the more that can even be associated with people's own use and consequences they experience. I always cite Sandra Wolfson. She's a researcher that showed that with cannabis, the most significant misperceptions of cannabis use come from those that use most heavily. So we have seen, compared to cohort 1, perceived frequency of medical marijuana use is higher in the last 3 cohorts compared to the first. Including, I mean, if you look at the far right with cohort 6, when we ask how often you think the typical person your age living in Washington uses medical marijuana, I mean, you've got, just even looking at the once a week or more, if you add that 9 plus the 12 plus the 4.5 plus the 11.5, I mean, that's a striking finding. You see that it's almost 40%, essentially 40% of people assume the typical person their age is using weekly or more. If I go back a slide, you see that it's that's not the case at all. When we look at even what are most people doing? Not using. It's the inverse of each of the prevalence rates that you see here. When we ask, what's the typical person doing, you can see that only 34% got that right in cohort 1. That's been hovering around 27, 28, 29% that got that right for the last 3 cohorts. So when we have over 70% of people perceiving that the typical person is using, there's an opportunity to correct misperceived norms. Any past year recreational, non-medical, personal use, this is going up. And when we look at the regression models compared to cohort 1, we see a significantly higher prevalence for cohorts 4, 5, and 6. You see a significant increasing linear trend, meaning that over time, rates are going up. So much so that when you look at odds ratios, the odds of recreational or non-medical use are 3.5% higher with each successive year in cohort. The age guide cohort interaction is non-significant. It's a different type of model with regression. When you split the model by over and under 21, it is the case that it's the 18 to 20-year-olds, from a statistical significance standpoint, we're not seeing a change over time. When we look at the increasing linear trend in past year use, though, there is a significant increasing trend over time for the 21 to 25-year-olds. Odds ratio is 1.055. That is significant. It means with each successive cohort, the odds of reporting non-medical use are 5.5% higher. And that starts to tell a very consistent story when we look at other analyses. At least monthly, that's increasing over time as a linear trend, and the last 2 cohorts are higher than the first. So you can see that compared to cohort 1, higher rates of at least monthly use for cohorts 5 and 6, and that significant increasing trend over time. When we split the model by age, it again seems to be the case that that's particularly true for 21 to 25-year-olds. And finally, at least weekly use. There's a significant increasing linear trend in people reporting at least weekly use. When we look at it split by age, it's again the 21 to 25-year-olds that you see this significant increasing trend for. So, I mean, what can we certainly look at that most people aren't using? What can we say, though? That over time, in this overall category of 18 to 25-year-olds who are higher risk, we are seeing use of at least past year, at least monthly, and at least weekly going up. And it does seem to be the 21 to 25-year-olds for whom this is most the case. Perceived norms, we see that cohorts 4, 5, and 6 have higher perceived recreational marijuana norms compared to cohort 1. Cohort 2 actually has lower norms, which is interesting, but overall, a significant increasing linear trend over time. You've literally got, if you look at the far right in cohort 6, 20% of 18 to 25-year-olds estimate that the typical person their age is using every day. Simply not true. And again, if you look at why that matters, the fact that we have over 30 years of data to say that as perceived norms tend to go up, actual use tends to go up. Certainly, we don't have the ability to look at in a causal way what's driving what here, but perceived norms are increasing and perceived use is increasing. We ask people where they get marijuana, if they are people that report that they've used. I color-coded in yellow, a decreasing trend that's significant, and in blue, an increasing trend that is significant. Those of you that have been around this project for a while or have heard me present on this before know that the single most debated item we had on this measure was, and I quote, the second one down, gave money to someone. The original version of the Young Adult Health Survey actually had it worded, got it from a dealer. And when we sent this out for comment and review, we heard from a number of people that had done this research for a while, including partners at the RAND Corporation, that they said if people are going to get paranoid and or go, aha, you're trying to find this illicit market, they said that this is where your survey will get either sabotaged or your data will stop being meaningful. So we changed it. The good news is it doesn't have anything that sounds, in quotes, scary, like dealer. The not as good news is this could include buying it from a dealer. It could include giving it to someone over 21 as they walk into a store saying, keep the change, I'll be over here. It could be asking your 22-year-old roommate, hey, when you go to the store, can you pick this up for me? So that's the only category that gets a little bit more challenging to interpret. Getting it from friends has gone down over time for 18 to 22-year-olds across cohorts. Getting it from someone with a medical marijuana card or a medical dispensary, you can see the significant drop-off that occurred in 2016. And you might recall that that's, of course, when the Senate bill led to the closure of medical dispensaries. What has gone up? Giving money to someone, getting it from family, getting it from parents with their permission. So particularly as we look at the data that continue to show how influential parents are, I think that's something that's worth exploring as we move forward. Where 21 to 25-year-olds get it, it's pretty much decreasing everywhere except getting it from a retail store. What's interesting is that it's not solely become getting it from a retail store. Getting it from other sources are still there. It's just that they have declined across cohorts over time. Driving after marijuana use. 2020 started with the data that we saw about the percentage of drivers with THC present involved in fatalities had gone up since December 6, 2012. Keep in mind that Initiative 502 set as a per se limit for driving under the influence 5 nanograms of THC per milliliter of blood for those over 21 and any positive amount for those under 21. It's not, in quotes, the same. Even though you can't see me, I'm making the in quotes, which I find to be a little annoying that I'm doing that to myself. But it's not the same as being legally drunk, but you see the same impairments in reaction time and ability to shift focus as we see at 0.08%. So the million-dollar question is, well, how long does it take to get below 5 nanograms? Most recent research is suggesting 6 hours, and potentially, if it's really potent stuff, don't even drive that day. But at the time our study launched, and at the time voters voted at I-502, what was significant, and in the literature, was Groten, Herman, and colleagues' recommendation that people wait at least 3 hours, because the belief was if you drove within 3 hours, you were likely above 5 nanograms of THC per milliliter of blood. So when this first came out in 2014, we were really disappointed to see that essentially half of young adults that reported using marijuana in the last month also reported driving at least once. You don't tend to see 49.41% of people who drink report that they've driven under the influence. We were seeing a different story here. Thankfully, these rates are decreasing, but they are still at high rates. You can see that cohorts 3, 4, 5, and 6 are all lower than cohort 1, and there's a significant linear trend. I will say again, this plays to none of my comforts at all because I can see and hear nobody, and honestly, I haven't seen anything come through the chat. So I have this huge leap of faith that this is still working and people can still hear and see this. Could at least one person type in the chat if you're still with me, so I know that this is happening?
Jason,
Yes.
we had one question come in. Someone
Okay.
was wondering if the cohorts were for ages 18 to 25 or 20 to 25.
18 to 25. All of these are 18 to 25. All of these are 18 to 25, which is why we have the ability to split. If I go back a slide, this is why we're able to look at 18, 19, 20-year-olds separately from 21 to 25. So we have impressive representation across each of those ages in that 18 to 25 category. If there was any confusion on that, I'm glad someone asked, so thank you.
There is another question. Oh, sorry to interrupt you.
No.
There's been another question. Have you disaggregated results for American Indians, including Alaskan Natives, Alaskan Indians, I believe, in combination with other races? We have seen this for school ages with the Healthy Youth Survey. So is this happening with the young adult?
Yeah, you will see on my last slide, and I'll just do the spoiler alert now, that Dr. Katerina Gutmanova at the University of Washington got a grant from the National Institute on Drug Abuse for secondary data analysis using this very, very rich data set exactly for those types of issues, looking at if there's disproportionate impact following over time as a function of cannabis legalization, looking at differences geographically, looking at differences based on race and ethnicity. So the good news is, yes, those types of analyses are being run. For the purposes of today, I'm continuing to show the data we've been reporting over time that we're able to do as part of our contract with this data analysis. But that is something that's been of interest to us, and there literally was not the time or FTE available to do this. With Katerina's grant, it gives us the opportunity to have dedicated data analysis to look at these really important questions. So I'm glad you asked. My hope is you will see a webinar starring Dr. Gutmanova sharing those exact results once that's all completed. I will take the silence as a cue to me and keep going, Jason, so I'm going to keep going. Average age of initiation is going up for marijuana. Now, that takes some time to interpret. Those of you who do work in universal or primary prevention, what's the goal? You're trying to delay the initiation of use, keep abstainers abstaining, which would mean you would want to see people using at a much later age. What this means is it's not that we've delayed initiation, it's that more people are actually initiating use. So when you look at the overall percentage of people that use, since that is going up, there are more people who historically have followed a trajectory of remaining an abstainer who have initiated cannabis use. So alcohol, no differences across cohorts, no significant linear trend. Cigarettes, no differences across cohorts, no significant linear trend. For marijuana, each cohort is significantly older than cohort 1, meaning there are more people initiating at an older age. The linear trend is significant too. So, I mean, if we have time for discussion, we can talk about what this means, but I think it's important to keep in mind folks were encouraged and even told that the idea of Initiative 502 is that it would not be creating a new market. There's the chance that, in fact, a new market has been created, especially in this 21 to 25 year age group where folks have access legally to buying cannabis. Other substance use is trending downward. So we see a significant decrease, linear decrease for alcohol, cigarettes, pain users to get high, and heroin. And also consistent with decades of research, as perceived risk of marijuana tends to go down, data from the Monitoring the Future study shows that actual use tends to go up. As perceived harm tends to go up, actual use tends to go down. If you look at what I've just shared with you over the last few slides, that holds completely. We've seen over time a significant decreasing linear trend for physical risk of occasional and regular marijuana use, psychological or emotional risk of occasional or regular marijuana use. With alcohol, we've seen a significant increasing linear trend for physical risk of 2 drinks every day, psychological risk of 2 drinks every day, The one thing people have held steady on is they believe it's physically risky to have 5 or more drinks every weekend, but you see an increase in psychological risk. Keep in mind that this again hangs not only with existing theory and existing data, but it holds with our data, that we're seeing perceived harm go down over time for marijuana. We're seeing actual use go up. We're seeing perceived harm for drinking go up. We're seeing actual use go down. So for the purposes of today, I'm going to share with you 1,571 folks followed over time. These are the same people followed over 6 years. Past year, medical marijuana use is significantly increasing. The last 3 years were all higher than the first year, and a significant increasing linear trend. Past year personal use is significantly increasing. Keep in mind that this does not hold with other literature. Cliff Fillmore's research in the 80s about the maturation effect for alcohol shows that as people get older, you tend to see things like use go down. There is literally a maturation effect. That's not the story we're seeing when you follow the same people over time. Past year use is going up. At least weekly personal use is significantly increasing. This is a linear trend that's significant, plus 16, 17, and 18 are all significantly higher in past week prevalence than 2014. Consistent with other stories, the differences across years are, the p-values are significant when they're the asterisks varying from 1, 2, or 3 asterisks, and you can see a decreasing linear trend for almost every source, getting it from a retail store, going up over time. So when we look at strengths and limitations of this study, I mean, it is a sample of convenience, and the good thing is that that does afford opportunities, like turning up the dial on making sure that typically underrepresented groups are represented. By weighting the data, it does boost and allow us to at least make statements with greater faith in our ability to generalize. The use of weights, again, can be a strength, but it also, weighted data has been adjusted. The good news, the weighted data matches the unweighted data. But in the spirit of acknowledging limitations, we list that as well. Finally, how great would it have been to have collected data prior to I-502 being made effective? We started data collection in 2014, and I still remember the first 2 years we would present these findings, we didn't know what story they told. And most of the questions people had were about the methodology. But my goodness, as someone that likes to look at data as critically as I can, and always maintains a healthy skepticism about what we think we may have found, this is starting to tell a very consistent story over a 6-year window. So that said, it certainly would have been great to have data pre-2012, or at least starting in 2012. The strengths, it is a sample of convenience. And again, that lets us reach harder to reach populations. Response rates for population-based, more population-based sampling approaches tend not to be very large. Knock on wood, we've not had that case. And so by using multiple methods, we have much larger samples than many studies tend to get. And this has also very much been a collaborative effort. To this day, my favorite document we've ever worked on was the first draft of the Young Adult Health Survey. At one point, the words in the comments and track changes exceeded the length of the survey. That's awesome. And I don't think you tend to see that many measures have that many sets of really, really smart eyes look at them. We've gotten input from key stakeholders every couple of years. When those of us that do work on college campuses and high schools started hearing people talk about juuling, we stuck juuling questions in, and we became the first survey in the state to assess juuling, for example. So I feel like we've been able to be very, very careful to not adjust the surveys in a way that would somehow eliminate comparability over time, but we've been able to include things as they become relevant and noteworthy and of interest to our partners in the state. So next steps, we're in our 7th year of data collection right now. We added questions on use during quarantine/stay-at-home orders and impacts of COVID-19. We jumped on this with our institutional review board so we could get modification approved, so we could ask questions about people's reported use during this time. I feel like in some ways, no matter what happens moving forward, 2020 will have an asterisk by it in terms of what do we interpret with this. And so adding questions, we asked about impacts. Did you lose a job? Did you have to alter plans for an important life event? Like, we want to look at what people have gone through in this age group, as well as what's happened with their substance use. I feel like it's tragic what has happened for many people. It's an opportunity to really contextualize what we're seeing. We're continuing to disseminate to key stakeholders. We'll be working with the Washington Healthy Youth Coalition tomorrow and being able to share data there. And I made reference to Dr. Gutmanova's secondary data analysis grant that will allow us to look at everything from geographic data, people's proximity to outlets. Research with alcohol shows that the more alcohol outlet density, the more drinking. Are people who are in settings with high cannabis outlet density reporting more use? We're going to be able to look at those really important questions about impacts as a function of race, ethnicity. It's such a rich data set, and I'm very, very grateful that we continue to get to collect these data. So with that, that's my email address, jkilmer@uw.edu. I will send a PDF of these slides to be shared with people that were on this webinar. But I guess at this point, if we still have the time, I will stop talking and open it up for questions, discussions, or anything else that folks want to discuss. Thanks for the chance to present to you today.
If anybody has any questions, please feel free to put them in the chat box, or you can raise your hand and speak as well.
We have a few questions in the chat. Someone states, do we know if older age groups are also starting to use beyond what is covered in the young adult healthy survey data? Say 40-year-olds starting to use as well.
That's a good question. I mean, that's data that would need to be collected, and of course, our data set's 18 to 25-year-olds. So, looking at other age groups would certainly be something that would be an important research priority as well. Obviously, 18 to 25-year-olds are the group that tend to report the most use, and are, unless you're on a college campus, tend to be a pretty understudied group. We have a really good proportion of folks in our study that are identified as being in a college setting, out of a college setting, in a military setting, you name it. So we're able to look at things like that as well. But someone interested in looking at older adults in Washington, that's an important research question too.
Thank you, Jason. The next question was looking at long-term. Is the data starting to see people at 18 years old to 25, or is this 25 years and older?
Well, keep in mind, every cohort is 18 to 25, but cohort 1 was 18 to 25 in 2014. They became 19 to 26. Next year, they became 20 to 27, and so on. So, you know, we're getting old people in our study now, which is kind of exciting. So as we continue to follow cohorts over time, they are getting older, and you know, we're all aging with them, but we're able to follow them over time. So the longitudinal analyses were the same people as they got older. The cross-sectional studies were completely different snapshots in time of the same age group, 18 to 25-year-olds.
Thank you. Next, does a young adult survey ask about housing and show housing status, like people experiencing stable versus transitional versus other housing?
Absolutely, and that is, again, in our secondary data analyses goals. As Sandy knows, you know, so much of our ability to conduct this, we try and do this in a way that's as budget sensitive as humanly possible. There's very little people power on this project other than running it and being able to do dissemination to key stakeholders. So, you know, when we have the variables we're being asked to report on, this could have been a day-long presentation, which I'm sure you all have been excited to hear. But there's so much more we can do. We do have those data, including if people are reporting being homeless or having non-stable housing. And so that type of analysis is what we're doing as part of Catarina's secondary data analysis project.
Thank you. Another person was wondering if there's any variability of results based on cannabis products, such as flower, concentrates, edibles, etc.
We asked this, and we've been able to ask differently: smoking, vaping, eating, drinking for the infused drinks, food as a tea, dabbing, and we ask about people's means of use. And we can certainly take a look. One of the things that we've been interested in looking at is we've done some exploratory analyses looking at for endorsing symptoms associated with cannabis use disorder. There's literature that has emerged that looks at, as people are using THC or cannabis with high THC concentrations and potency, which, you know, the market in our state is very, very high, and the concentrates are very, very high. We do see more endorsement of and risk for cannabis use disorder. So yes, we have that data, and the way that we've played with it a bit is looking at how, you know, what people's primary means of using winds up being, and we can explore if there's differences, especially for folks that tend to use concentrates in things like endorsing symptoms related to dependence.
We have another question asking, do you think virtual learning will have an impact on use if kids are on versus off campus?
It's a great question. Anecdotally, which there's always has a grain of salt with it, you know, my colleagues across the country have all said, you know, our internal data is showing some people are holding the steam, some people are decreasing their use, some people are increasing their use. A lot of it has to do with motives for use. If people say, I'm really, really shy and it's hard for me to socialize, well, face-to-face socializing is not really happening. At least it shouldn't be happening. And so I think this is why so many studies have jumped on trying to collect data, not only on what's happened since March, but even moving forward. We do know that it's important for people to stay connected. We really wish it had been called physical distancing instead of social distancing, because as we look at mental health issues, as we look at things like suicide risk, you know, we really want to be mindful of people not feeling, you know, overly alone or overly isolated during all this. But long-winded way of saying, I can look, well, I can't look anyone in the eye. I can talk to you through my computer and let you know these are data that are actively being collected right now. So we can find out what that move to virtual, what that impact has been with college students and with this age group.
Perfect. We have one final question.
Sure.
This question is, does the survey ask about age of first use? We're not seeing increases among high school students, so would the conclusion be initiation is largely happening once 18 plus?
That was this slide. So yes, we do ask about this, and more people are initiating marijuana. The reason why this age group is going up is not that the same people that would have used anyway are delaying their initiation, it's that more people are initiating at an older age. When you look across time, the larger cluster of people that tended to remain lifelong abstainers, that's going down. More people are initiating for the first time. So yes, we collect that data. Sorry if that was unclear when I presented this, but that's what this slide is all about.
Thank you so much, Jason. Sandy, back to you.
I will stop sharing my screen. Thanks, everybody.